Well, thank you so much for the warm introduction, for the platform, and for the opportunity to share some insights on the evolving role of heart failure-related cardiac shock. These are my disclosures. And the learning objectives, as we talked about, trying to untangle this spiral of heterogeneity with disease-specific processes. So THI is truly an innovation platform for all cardiovascular illness. And the history of cardiac shock probably started here. As we can see, this slide from the 70s of intra-aortic balloon pump original use, we can see that the mortalities from that time has remained unchanged. Fast forward almost several decades afterwards, the initial shock trials were instituted. And it's a picture from the hospital that I did fellowship, a large referral STEMI program in Western Massachusetts, which their shock trial patient is being platformed here. And I think this picture really elucidates a lot of the problems that have been now contemporary and the things that we're trying to tackle using real-world data to better trial design. Large proportion of these patients were supported only on inotropes vasoactives with absent hemodynamics, with a high dependence of mechanical ventilation and renal replacement therapy. In this unidisciplinary model of care, with the physician and the nurse caring stoically for these patients and the use of low-profile circulatory support. There were limited transitions for these patients and absent palliative care. Fast forward just recently, we have another negative trial for cardiac shock, the ECLS shock trial, in which a large proportion of patients on advanced stages of shock were placed on ECMO after acute myocardial infarction. But with a lot of questions raised, whether these patients were profiled appropriately from a hemodynamic clinical standpoint, whether their transitions were protocolized, and most importantly, whether these patients had an exit strategy. So as we know, cardiac shock has a lot of ongoing trials, and in the risk evaluation has now new semantic qualifiers like the SKY stage. However, there's more than shock severity to look into this. Cardiac function and hemodynamics and organ dysfunction, the etiology and phenotype, which we're gonna focus today on, the impact of cardiac arrest and brain injury, and all the other non-modifiable factors, including social determinants of health, that will impact the transitions of these patients. And as we look into the near future of all the trials that are ongoing for shock, we have to have these questions in our minds, whether these patients are really being profiled beyond the tag of a disease. And the problem is a little bit more complex since now mixed shock, not otherwise specified, has been identified across the cardiac intensive care units of North America in a large proportion. A lot of these patients not only have just IMI cardiac shock, we have ischemic, non-ischemic shock, and again, a lot of work to be done and an invitation to profile these patients. This is a typical day in the office, our institution in which we get consulted for mixed shock, not otherwise specified, on high inotropes and vasoactives, patients being transferred from out of hospital with really advanced hemometabolic involvement, in which, again, when we look back, they have had a previous engagement with the healthcare system, they have had prior hospitalizations or emergency department visits, and they have been treated for alternative diagnosis. So the problem is profound since, again, these patients are in medical ICU units across the United States with, again, most likely heart failure cardiac shock. Again, it's complex. There's a lot of issues to identify in this population, including the black box of postcardiotomy. So in addition to that, in our institution, we have this massive geospatial challenge for early referral. So putting all those things together, we wanted to bring a platform in which we put cardiac shock at the center of that pillar and create the whole program that is not only siloed into shock, but is really integrated into access to advanced heart failure, comprehensive therapy with remote monitoring, disease-specific and interdisciplinary focus like amyloid, sarcoid. And then again, in the original phase of the program, a lot of these patients understanding that they will come into our offices in the ICU in cardiac shock. The The next slides, I'm going to talk a little bit about the cardiac shock working group. This started in 2017, the day that I got my passport renewed in Boston. As you can see, it's walking distance to Tufts. So that same day that I had the appointment for the passport, I decided to meet in person Naveen Kapoor, which has been an instrumental figure, mentor, and friend. And we decided to start a registry of hub and spoke models for cardiac shock at 2 centers. And now fast forward, we are having more than 20 centers, not only in the United States, but across the world. And a lot of the data that I'm going to present and adapt to our daily practice stems from here. And with him and the help of the steering committee that I mentioned then, Dan, Rashad, Marid, and Shashank, we have investigated the problem in a little bit more granularity. The first insight that we had is that escalating inotropes and vasoactives were associated with high mortality. And I will say here continues to be associated with high mortality since this was well known from post-cardiotomy series 20 or 30 years ago. In our center, we have tried to adapt this as an alert in the medical ICUs or the cardiac ICUs, in which, again, inotropes and vasoactives trigger an alert. The other important insight was that hemodynamics in cardiac shock profiles are now identified. And as we know, right side predominant and biventricular predominance in shock for both IMI and heart failure is associated with a higher mortality. We have also demonstrated the association and most importantly, the impact and value of invasive hemodynamic profiling, in which even in advanced stages of severity, having full profiles with PA catheters can have an impact in survival. That combination of phenotypes, hemodynamic phenotypes, and metabolic variables have also led to important insights using large data or machine learning algorithms to identify profiles that are beyond just hemodynamics, like the cardiorenal profile, and the most importantly, cardiometabolic profile that has been evaluated in other registries, not necessarily from the United States, in this case from Denmark, to identify that patients that really have biventricular, renal, and liver injury have a highest mortality. Then when we think about our registry and try to incorporate in large data sets, we continue to see the signal of advanced sky stages is associated with advanced mortality. I think this is relevant because it gives us a good validation cohort to understand what is the current in-hospital mortality of the disease. And as you can see, for heart failure cardiac shock, which is the purpose of the talk today, we are at a 32%, almost 33% in-hospital mortality, which remains, I think, unacceptably high. So it all starts with trying to differentiate between IMI and heart failure cardiac shock, and how do these patients present to our day-to-day operations. And with IMI, it's a clear timestamp of an abnormal lab or a normal EKG that triggers a time-sensitive intervention. But as we know, with heart failure, there's a lot of ways that these patients can present, particularly when they're in the initial at-risk or beginning of their disease process. They can present to the office, to the emergency room, be discharged in their index hospitalizations, or directly into an ICU setting. So the clinical courses of heart failure cardiac shock are very different from IMI, but again, the goal should be longitudinal well-being. And the three trajectories that are identified in these patients are the need for heart replacement, but or death, in addition to native heart survival. So these three trajectories have been identified as our outcomes follow-ups in our different studies. I think importantly, what we have gained in the original versions of the registry is that the disease is complex. The majority of these patients are being identified in this hemometabolic heart failure cardiac shock under mechanical ventilation, inotropes, vasoactives, renal and hepatic injury with biventricular profiles, and with the use of high complex mechanical circulatory support, have the lowest associated native heart survival probability and the highest associated in-hospital mortality. So it really narrows these patients' probabilities to even be replaced or die in the hospital. And again, it's really a call to action to try to teach our referring physicians, our frontline clinicians to identify this disease a little bit more earlier than what we actually feel in transplant centers or in bad centers as a day-to-day operation, perhaps already too late. And that has been demonstrated further with the impact of transfer of heart failure cardiogenic shock that has on mortality. As we can see, patients that are being transferred have a high probability of mortality, a lower probability of heart replacement therapies. Is perhaps already too late for these patients to be transferred to the main high volume cardiac shock center. I think the other aspect is once they are in these cardiometabolic, again, biventricular profiles with renal and hepatic involvement, they will be defined as advanced stage, as SCAI stage E, and they will most likely stay there throughout the course of their illness. It's very hard to reverse once they're so sick. And again, this is, again, 20 sites that deal with this every day, but you can imagine for hospitals that don't have enough technologies or enough probabilities to care for these patients, this might be even worse. And the other aspect of the cardiac shock working group, which I think is most interesting for the future of enrolling in trials particularly, is that now we went from a semantic classification that the SCAI shock stages gave us, which is excellent and has helped a lot of clinicians have situational awareness, to have a more granular definition that correlates well with our daily practice, which again, markers of hypotension, hypoperfusion, and treatment intensity are incorporated. And now we have the possibility through an app that can be downloaded through the different phone platforms to actually follow your patients in the day-to-day trajectory to see where they started in a SCAI stage D to C with objective granular parameters. And I think this is very important as we round on these patients and we want to know when is the right time for transition them, whether escalation, de-escalation of devices, whether it's recovery, remission, or heart replacement, whether it's also futility or the need for palliation and hospice. Having that objective classification across the board until we have more information becomes very important. The other aspect has been based on the original PA catheter association with complete hemodynamic profiling and improved survival or reduced mortality in advanced SCAI stages. We had a closer look to the presence of PA catheters for heart failure-related cardiogenic shock, and what is the impact or associated impact in mortality when it's used early, when we profile early these patients. And this came out recently in the Journal of Cardiac Failure, and patients with PA catheter did have a positive association when it's done early. This has also been replicated by the other registry of cardiac critical care, which again, the in-hospital mortality on patients that had been exposed to PA catheters was lower than those that didn't. So this has prompted us to actually design the first trial from the cardiac shock working group, in which again, de novo or acute on chronic heart failure patients are going to be randomized to early PA catheters within 6 hours or not, and being the primary endpoint mortality. And this is a trial that is enrolling, ongoing. We have 4 sites actively enrolling, and we're planning to, of course, have more sites join across the next years. The other aspect that all these observations have triggered is that there's a little bit more than just profiling and device and exit strategy. There's a whole bunch of things that can be done, particularly within the first 24 hours, that have to do with critical care interventions, with cardiac-related interventions. And again, this concept of protocolizing care for specific phenotypes starts to evolve and be applied in actually new cardiac shock trials, like, for example, Protect and Recover. So the idea will be to not only focus on the phenotypes or the devices, but also on the opportunity of cardiac-specific interventions, whether it's ablation, valve interventions, and all the aspects that are related to mechanical ventilation, drugs, etc. The concept applied to our program has been trying to early identify SCAI stages, and if we're not able to identify these patients early, try to transition patients with SCAI D and E to C, looking and anticipating longitudinal transitions, whether it's recovery, remission, or replacement, with the opportunity of having ambulatory platforms in which these patients are in one device, in one drug, ambulatory, not intubated, in which, again, we can start the journey of trying to understand who these patients are, having not only the phenotype of their cardiac issues, but also all the other aspects that have to do with nutrition, psychology, physical therapy. There are certain platforms that allow non-dependence on the fracturing heparin. There are some aspects of guideline-based medical therapy that can be intervened upon. And again, the focus when we don't know these patients and presenting these transfer with hemometabolic shock in SCAI stage E is to focus on remission and to do everything that we can to send this patient back home with their native heart. So that the journey starts once you have early recognition and stabilization to trying to understand. We try to have a detailed ischemic evaluation, trying to rule that out on all our patients, and use, if needed, multimodality imaging to try to understand what is the true phenotype. And I think that is one of the features that has allowed us to open at least a pathway to myocardial recovery and remission. One of the issues that we continue to see is that patients that have been transferred with out-of-hospital cardiac arrest. And I think that is very important as we incorporate devices, severity, and expectations. And we have also shown in both phenotypes, in heart failure cardiac shock and MI cardiac shock, that the impact of out-of-hospital cardiac arrest is profound in terms of their in-hospital mortalities of different illness altogether. And it's not saying that we shouldn't accept these patients and try to help them, but we need to understand the expectations are different. And as we get patients from different areas with these geographical challenges that we have, this has become an important endpoint to look upon. And now just digging deep into the heart failure related cardiac shock situation. We published this last year, and the idea was to try to phenotype further heart failure related cardiac shock in de novo. So the first time that it was diagnosed, or acute non-chronic heart failure when the patients have prior hospitalizations with shock. In terms of de novo, there's still a lot of work to be done to try to understand why these patients have heart failure. As we talked about, the majority in this particular cohort were classified as idiopathic. And as you can see in terms of their transitions, patients with de novo had a higher in-hospital mortality. Patients with de novo heart failure cardiac shock had a higher probability also of native heart survival and a lower probability of heart replacement therapy as compared to acute and chronic. So there's differences. Perhaps this difference could be understood in different from different perspectives, but one of them could be that these patients were not previously plugged into a advanced heart failure program. They didn't have a pathway towards heart replacement, a pathway towards deep phenoprofiling. And again, you are in a time-sensitive situation in which you're trying to figure it out and your options are limited. However, for de novo heart failure, I think we all can recognize that fulminant myocarditis is truly the ultimate stress test for cardiac shock centers. These patients that come in previously healthy, talking to you in the emergency room with perhaps some mild chest pain, and 8 hours later, they have a lactate of 10. They're intubated on high inotropes and vasoactive agents. And I think these patients do require a special cohort of best understanding what is the best trajectory, but their severity really dictates sometimes their treatments. The majority of these patients will end up on high-profile support, whether it's via ECMO or biventricular transvalvular pumps. And then it's also a disease that has a high probability of recovery if things are done right by the interdisciplinary team. So I think among the limitations of this original analysis is trying to think about fulminant myocarditis as a different truly entity. The other aspects of the analysis that were relevant is that heart failure cardiac shock that starts at low scale of severity is progressive. The timing to progression, again, matters. And it's important to understand that for our referring physicians or for our clinicians caring for patients in early stages of shock, there's a good possibility that these patients will progress. So it's important to have the opportunity of having early intervention, early crosstalk, and whatever is the device that it's been chosen, to have the opportunity to identify these patients earlier. Just talking as a plugin with and as a comparison with the IMI cardiac shock phenotypes, we also have seen this similar progression of disease in which, again, the majority of these patients from SCI-B will be escalated. This has sort of brought up the issue of patients requiring, again, early surveillance and really early referral. And again, B is not for bueno in Espanol, it's B for bad. So we really think that these patients really require more attention. Same sort of similar impact from baseline to maximal SCI stages. And when we think about the in-hospital cardiac arrest in heart failure cardiac shock, and I think is perhaps one of the key messages for this lecture is that when that happens, the mortality is almost tripled. And I think that in-hospital, whether it's de novo, acute and chronic, heart failure, cardiac shock, and I think this is truly a call to action. And when we see these patients in different hospitals, identify the patients early, we know that the patients have shock. What are we going to do to prevent in-hospital cardiac arrest? Because when that happens, there's a different disease altogether. Of course, there's SCI stage E, but there is a series of interventions that follow and that impact the mortality and the disease trajectory of these patients. And as we looked at this in the IMI cohort, it's a similar thing, doubled. Perhaps your interventions are readily available in the cath lab, so that's why it's not triple, but still, it's pretty bad. And I think as the future evolves for heart failure, cardiac shock, I think the preventable progression to refractoriness is going to be what differentiates between quality and excellence between programs. And I think as we think about stars for cardiac surgery or stars for quality of different cardiovascular interventions, the idea of identifying patients in the early stages versus extremes is going to be a high I think that we need to pay attention to. What are we doing at our health system? We have a protocol in which we try to make it as hemodynamically driven as possible. Of course, there are inclusion of the clinical aspects, the imaging aspects, but really we try to resolve the hemodynamic issue by profiling early with PA catheters. The role that we have had in the last 2.5 years has been trying to alert clinicians that we're more focusing on the imaging, that we're more focusing on hemodynamics or clinical to integrate the three of them. This has been translated into a position statement in the AHA that I think is excellent for the care of patients with cardiac shock. And for us, the most important thing has been trying to increase the adequate use and follow-up of patients with PA catheters. And we have these QR codes for patients, nurses and fellows at the bedside, and these posters for how to use appropriately the PA catheter. Because if we're going to use invasive hemodynamics, we want to make sure that the information that is longitudinally presented is right. And if that is good, I think the clinical and the imaging follows usually in a good way. In terms of our temporary mechanical circulatory support platforms, yes, we have a different perspective from hemodynamic, left heart, right heart, biventricular support, but we're very focused on the ambulatory aspects. We also try to make sure that whatever we do, we're thinking that it might have an impact on heart replacement or heart recovery. And hence, we try to choose platforms that have a most favorable hemocompatibility. And I think in this context, the opportunity for surgical transvalvular pumps allows us to use bicarbonate instead of unfractionated heparin, and has made a big impact in the transfusion requirements or the development of HIT, for example. And again, that impacting a very better trajectory to heart replacement. Just like we choose devices, we have hemodynamic-based transitions in heart failure cardiac shock. We came up with this at my time in the Cleveland Clinic, in which we have device tailoring based on hemodynamic profiles. I think this is an important aspect as we continue to see that when we see patients that have been listed for transplantation, there's a very few percentage that had transition from a listing to a recovery candidacy. And I think as we continue to evolve as a field within cardiac shock and transplant, having detailed documentation on weaning and escalation will be important. The more we know about the trajectory or the ultimate trajectory of heart failure cardiac shock, I think clinicians will feel more comfortable attempting those transitions. The truth is right now, when we see a patient with very severe illness, we stabilize them with temporary MCS, and we see some signs of recovery, but not full recovery or remission. There's a lot of anxiety of trying to remove all the support and send them home because we have seen these patients come back. So there's a lot of things to learn from this as a field, I think. But it all starts from having at least protocols or platforms for weaning and escalation. For us, this is how we like to have our patients before a decision of replacement or remission. Again, one device, minimal inotrope utilization, that transition from advanced stage to a stabilized situation, and documenting why we utilize high-profile support in this particular case because they were not responding to counterpulsation. I think counterpulsation continues to be utilized. Is the most common temporary MCS utilized in the heart failure cardiac shock cohort. I think that ambulatory counterpulsation is possible, but with a protocol that addresses the malposition issue, with a protocol that allows us to understand the anatomy adequately in the cath lab. And it's very useful, particularly for these type of patients in which they have restrictive heart disease and a transvalvular pump or VA ECMO will be deleterious to make the full transition to a heart replacement, like in this case of AL amyloid that we had at Temple last year. Of course, if they have really the requirements of high profile support, we still try to choose supradiaphragmatic ambulatory platforms, even if they're combined in this particular case with transvalvular 5.5 for left heart support and a Spectrum cannula that is venopulmonary ECMO with venopulmonary ECMO capabilities and oxygenation in this particular case, in the case of presumed myocarditis. We choose this platform over ECMO just based on the physiological aspects that ECMO sometimes will have in the already known failed heart. But that doesn't mean that ECMO is not utilized, particularly within hospital cardiac arrest. And we'll see these patients that present on ECMO requiring to be vented with a transvalvular pump, then transition to an axillary pump, and then ultimate transition to a durable pump. So that transition continues to evolve. ECMO is here to stay at the very least as of now. There's more and more ECMO utilization, and it's not uncommon to just receive patients that are already being supported on ECMO, since that was the easiest and most feasible high-profile support that they have in the peripheral hospital. But it's important on heart failure cardiac shock understand the hemodynamic impact, increasing afterload that it will have on the failing heart. Understanding that these patients have a distinct pathophysiology, particularly the patients that are on acute on chronic heart failure, that have a series of already congested lungs, injured liver and kidney, to say the least. And hence, it's important that if we accept these patients on VA ECMO cardiac shock, that we have some LV unloading solutions available, and there's multiple of them depending on the center that you work and your capabilities. What we have looked at is that in patients that have a combination of VA ECMO with another device in heart failure cardiac shock, there's an appearance of a signal for those patients that have acute on chronic heart failure, that the combination with a transvalvular pump is associated with reduced in-hospital mortality. What we try to do when these patients require truly high-profile support is to also still stay supradiaphragmatic and try to have our surgeons proceed with 5.5 and an arterial cannula in this sort of Y axis distribution of a graft. And in this particular case, we have an arterial cannula, the Impella 5.5, and a venopulmonary ECMO in the subclavian vein. So it is possible to have full support that is supradiaphragmatic if you have skilled surgeons that are involved and part of the team. And it really allows them to transition to hopefully univentricular support, and again, give an opportunity for recovery or a more easy transition to either a durable valve versus transplant. Again, it's important to have the concept of right heart support coupled to the lungs, and for us, decongestion is coupled to recovery of the right side of the heart, since again, the right side of the heart is seeing the congested lungs as their primary source of increased afterload. We have been very invested in making sure that when we have these patients on high profile support, we have an aggressive decongestion regimen to try to stabilize pretty much the septum with flows and decongestion at the same time. And again, trying to resolve the question of this is a biventricular problem to a univentricular problem. I think it's important that as we continue to evolve in the field, that we have the intentional intervention of native heart survival, over heart replacement, well understood. It's going to take time to see which patients are the ones that are candidates for that. But a combination, I think, of improved perfusion, effective decongestion, resolution of end organ dysfunction, and achievement of hemodynamic goals really opens a platform to understand whether these patients can really be weaned or not. And I think that is part of the goals of the program, to make sure that we get to that stabilization phase, so then we can actually address recovery for these patients. And I think that's sort of what the field is looking at the moment, trying to unbox these transitions in which we see patients just in a cross section of advanced sky stages, and really try to transition them to whatever is needed, like in this particular case that we were talking in the beginning of the talk. Again, the patient was profiled, had left heart predominant cardiogenic shock. She had a transvalvular surgical pump inserted, and then the whole 30 days of recovering this really horrible hemometabolic shock with renal injury included, to the point that she was able to rehab, have nutrition, no need for PAC since we have achieved hemodynamic goals. And then all that time invested was actually time well spent, since she just had a post-op length of stay of 3 days after a durable valve was placed, and the patient was able to go home. Even if it was a long length of stay, it was a prehab long length of stay, and then the whole longitudinal follow-up begins. Again, that case sort of explains a little bit about what we have been focused on in trying to replace patients that are on hemodynamic goals. We have seen, of course, less pre-op bleeding based on the band, ICU length of stay, and need for renal replacement. It has really come into sort of a reflection of understanding these longitudinal transitions on patients that have been, for example, exposed to ECMO and then transplanted or VADed, why their outcomes are just different. And I don't think it's really the fault of ECMO in itself. It's perhaps that patients were placed on ECMO and they were still not stabilized from an end organ dysfunction perspective before they were transitioned. And the fact that they were on ECMO rushed teams to perhaps move forward with a replacement. And I think that's perhaps one of the narratives that could be changed as we have more information. This is how we ideally like to send patients for replacement with normal hemodynamics. This picture was sent by the surgeon because the hemodynamics before and after temporary and durable LVAD matched. So it was the first time that I've seen this, but it was nice to see that same flows were happening at 4 liters on the 5.5, 4 liters, almost 4 liters on the HeartMate 3, and they have matching hemodynamics pre and post. And as you can see, the critical care aspects have been really simplifying these patients: normal lungs, normal liver, normal kidney. Really, they don't have infections. They're walking and eating. So that's very important. We have 10 minutes. I will just give my final thoughts in regards to where I think the field continues to go and should be going. I think the interdisciplinary teams are key to longitudinal success. That is a true key here. It's not a one-man show anymore. I think the fact that we can connect different specialties in cardiology with a shared communication, common language, coordinated care, having time-sensitive quality improvement and easy access to these operations, to knowing the data right now, how are we doing, how can we look ourselves in the mirror, so we can then show that data to the people that actually take care of these patients in the original early stages of disease becomes very important. Having platforms for situational awareness, shock dashboards, and then going back again to the patients and caregivers so we can actually know how they're feeling with all the things that we're doing. I think that early access to cardiac shock diagnosis is very important. Of all the protocols that we have at Baylor, I think this is my favorite, in which is, again, a very simple acronym for suspicion and very simple guidance of what we need to start the activation of the team. We oftentimes connect cardiac shock with innovation in pumps and innovation in the therapies that we give them through mechanical circulatory support. And we were talking about the history of THI in the 1970s, and there are some countries that are neighbors to us, for example, in Mexico, that only have intra-aortic balloon pump. And just by changing the narrative or changing the perception of how to profile these patients early, we're starting to see changes in survival. And again, these two collaborations show that patients that are being profiled early, decongested early for IMI shock in this particular case, have improved survival. And I think these are the type of things I think are important when you have centers like THI that are innovators to try to share throughout the rest of the world what can impact not only locally but globally. And I think for us, has just been profiling has made a big impact not only here with us, with all the platforms, but also across the world with limited platforms. Of course, referring early impacts expectations in heart failure cardiac shock, knowing that the advanced heart disease team has probabilities to identify and phenoprofile these patients, but the sicker they are, the farther away from this profile we have, and the farther away from realistic expectations to well-being. So I think that's been an important message to our referring. Of course, it's an acronym that continues to evolve, but how we get here is very important. How we got to this heart failure cardiac shock in the unit, if there was an opportunity to refer early, and I think the majority of these patients had a criteria to be referred early, and creating access for that becomes important. I think for us, we have had an increase in the referrals for sure, in an impact in heart failure, IMI, and CABG mortality, which we're very proud of. And again, I think that vision in the last couple of years have been executed in a way that, at least starting with shock, going all the way up, we have made an impact in a community that didn't have access to advanced heart failure care. I think we can work on disease-specific transitions, amyloid, restrictive cardiomyopathy, dilated cardiomyopathy for both heart recovery and replacement. I think there's a big issue with normalization of palliative care access in cardiac shock, as we know, so we need to work and be better on that. We need to incorporate social determinants of health in the cardiac shock transitions, open that narrative, since again, that is truly the foundation of a lot of these problems, is that patients were not aware that they were that sick. And of course, align patient and caregiver and program goals early, which I think patient experience, patient-reported outcomes, and having the translational aspect of research to the patient experience aspects of research is that sort of the ultimate goal. And I think a place like THI is leading the way on that. And of course, ultimately, having a connection of heart failure to cardiac shock across the healthcare system for us, we're also very proud of this connection that is novel, that is new, trying to not only focus on cardiac shock or the sickest of the sick that need Biden transport, but going throughout the whole spectrum, not only at Temple, not only at Dallas, but in the whole Baylor's cardiac system. So a lot of these things, Dr. Rogers, which again was one of the persons that inspired me to focus on cardiac shock, have been said by him many years ago. He was talking about the guidelines. He was talking about team-based approaches and shared decision-making many years before this lecture. So I just want to thank Joe for all the inspiration and all the influence that he had during his time at the SHLT and then longitudinally. And I'm very honored to be here. I cannot just hide behind all these slides, and I think just wanted to just share some perspective from my personal life. Right now, I'm just seeing my kids grow and knowing that, acknowledging that they're growing fast, acknowledging that they're looking at me and they have been looking at me throughout these past 10, 11 years. And I just want them to become sensitive creatures. I just want them to see the sky that we had yesterday, for example, and be inspired by that. And I know they are. So again, thank you so much for having me. This is the whole team that we have sort of incorporated as similarly to the new ISHLT vision. I want to thank also the Cardiogenic Shock Working Group, if they're listening. A lot of this work is thanks to them and to the whole team at Temple. Thank you so much.